Welcome to Healing Horizons, the podcast exploring the science, spirit, and stories of Ibogaine therapy. I'm Chris Daniels, your host. Today's episode, Navigating the Unknown, is a safety-first guide to what happens before, during, and after an Ibogaine journey in Mexico. We'll cover why Mexico, origins and ethics, candidacy, vetting clinics, screening, medication washouts, intention and preparation, travel, dosing day flow, the immediate recovery window, integration, costs and red flags, realistic outcomes, key questions, and brief success snapshots. This is educational, not medical advice. Please consult qualified clinicians. In Mexico, Ibogaine is not scheduled federally, allowing medical clinics and retreat centers to operate within health and business laws. That access draws experienced teams, emergency-trained doctors, nurses, and facilitators who understand the psycho-spiritual terrain. Strong programs blend hospital-grade monitoring with respectful ceremony, quiet rooms, intention circles, music as container, not spectacle. The aim is pragmatic safety and cultural humility, so you receive continuous clinical oversight while feeling held in a dignified, meaning-centered process. Iboga and Ibogaine originate in Central and West Africa, where Bwiti lineages have stewarded Tabernanthe Iboga for healing and initiation. Ethical use means acknowledging those roots, avoiding appropriation, and supporting sustainability. Ask clinics about sourcing synthesized alkaloid to reduce pressure on wild plants or farmed, legally exported material. Are replanting or Bwiti-led community projects supported? Respect looks like transparent education, consent-based ceremonial elements, and remembering this medicine is a sacred tool for truth-telling, not entertainment. Ibogaine is explored for opioid, stimulant, and alcohol dependence, trauma-related patterns, and treatment-resistant depression. The right candidate has clear goals, support, and medical clearance. Key contraindications: structural heart disease, prolonged QTC or family history of sudden cardiac death, uncontrolled hypertension, serious liver disease, pregnancy or breastfeeding, untreated psychosis or mania, uncontrolled seizure disorders, and recent strokes. Risk also rises with heavy benzodiazepine or alcohol use, or multiple QT prolonging or serotonergic medications. Ethical clinics decline or delay when safety criteria aren't met. Vetting a clinic could save your life. Look for licensed physicians on-site during dosing, 24/7 nursing, continuous cardiac and oxygen monitoring, ACLS-trained staff, defibrillator, IV access, oxygen, suction, airway tools, and emergency meds. Protocols for electrolytes and arrhythmias. Written informed consent. And a named hospital partner. Demand transparent dosing philosophy and total costs, including labs, meds, transport, meals, and aftercare. Ask annual case volume, complication rates, and incident learning practices. Clarify integration, therapy, peer groups, and coordinated follow-up. Screening is non-negotiable. Expect a full history and physical, a 12-lead ECG with QTC and rhythm review, and labs, electrolytes, kidney function, and liver enzymes. Many programs add blood counts, fasting glucose, pregnancy testing when relevant, and infectious disease labs as indicated. Bring an exact list of prescriptions, over-the-counter drugs, and supplements. The team should reconcile interactions and, with consent, coordinate with prescribers. If potassium, magnesium, liver markers, or QTC are off, responsible clinics correct issues and may postpone rather than push forward. Washouts must be medically supervised. For opioids, many programs transition long-acting agents like methadone or buprenorphine to short-acting opioids under a prescriber. Then time Ibogaine when you're in clear, mild withdrawal. Benzodiazepines and alcohol require a proper detox first. Abrupt cessation can cause seizures, and Ibogaine is not a detox for them. Antidepressants, stimulants, and sleep agents are reviewed case by case. Drugs and supplements that prolong QT or boost serotonin, some SSRIs, SNRIs, MAOIs, tramadol, antihistamines, antipsychotics, antibiotics, 5-HTP, St. John's wort, may need pauses. Never stop or switch without your clinician. Intention sets your compass. Ask, what pattern am I releasing and what values guide me next? Journal honestly and involve your therapist so prep aligns with ongoing work. Favor process goals over magic thinking. I will face difficult memories with support. I will follow an aftercare plan. Choose 1 or 2 immediate behaviors: daily sponsor check-ins, scheduled therapy, structured sleep. Intention isn't control. It's a commitment to meet whatever arises with curiosity, courage, and compassionate discipline. Support your nervous system before travel. Prioritize consistent sleep, steady hydration with electrolytes, and nourishing meals, simple proteins, vegetables, whole grains. Avoid new supplements, crash diets, or cleanses. Stability beats experimentation. Keep movement gentle. Walks, stretching, light strength work. Practice daily mindfulness, brief breath work, or body scans to build skills you'll use during the journey. Reduce digital overload in high-conflict situations and trim commitments so the week after treatment is spacious. If trauma is active, schedule prep sessions to practice grounding, paced breathing, and orienting. Plan travel intentionally. Arrive 1 to 2 days before screening and dosing to recover from flights, meet staff, and stabilize routines. Confirm passport validity, any visas, and clinic pickup. Consider a trusted support person who respects boundaries and can assist afterward. Build buffer days post-treatment before flying home. Pack loose layers: warm socks, eye mask, earplugs, scarf, electrolyte packets, refillable bottle, simple snacks if permitted, lip balm, fragrance-free toiletries, a journal, a small grounding item, and post-treatment aids only if previously tolerated and cleared. The day before dosing is for orientation and calm. Review informed consent, meet the team, see the room, and confirm transport. Staff repeat vitals, perform any final ECG or labs, and recheck medications. Meals are light. Many programs ask you to fast from late evening except water or electrolytes. Use downtime to journal intentions, practice breathing, and keep stimulation low. Minimal screens, gentle music, maybe a brief staff-approved walk. On dosing day, expect quiet, dim light, and continuous monitoring. After baseline vitals, many clinics start with a small test dose to confirm tolerance. Then, if stable, deliver a carefully titrated primary dose. You'll have cardiac, oxygen, and blood pressure monitoring, with a nurse present and a physician nearby. Keep eyes closed, minimize movement, and let the process unfold. Speaking is optional. Do alert staff promptly for chest discomfort, severe anxiety, shortness of breath, unusual palpitations, or nausea so they can assist safely. Experiences vary. Early on, many feel a body buzz, warmth or chills, and sensitivity to light and sound. Nausea is common and discreetly managed. Ataxia, unsteady movement, is expected. Staff assist with any position changes. Psychologically, people often enter a panoramic review. Memory sequences, symbolic scenes, or direct insights about relationships, grief, or self-deception. Time can distort. Emotions can surge, then settle into quiet introspection. Not everyone has vivid visions. Some experience grounded clarity. The invitation is to watch without chasing and let meaning crystallize later. Safety is active, moment to moment. Staff track QTC and rhythm, blood pressure and oxygen, correct potassium and magnesium if needed, and are trained for bradycardia or arrhythmias. Seizure risk is addressed beforehand. People with recent alcohol or benzodiazepine withdrawal are not dosed until stable. Hydration is gentle. Small sips to avoid aspiration and electrolyte swings. A solid clinic will pause if you're sleep-deprived, intoxicated, in significant withdrawal, febrile, dehydrated, or if ECG or labs drift unsafe. Postponement isn't failure, it's good care. The first 24 to 72 hours are the gray day. Fatigue, insomnia despite tiredness, light and sound sensitivity, and wobbly balance. Keep stimulation minimal. Staff will assist with mobility and simple foods, broths, fruit, toast. Hydrate with electrolytes. Expect fragmented sleep and thoughts. Gentle reassurance, warmth, and quiet companionship matter more than conversation. Days to weeks later, Ibogaine, the active metabolite, can reduce cravings and lift mood, while sleep and energy slowly normalize. Use this plastic window to lock in new habits. Attend therapy, change environments that cue use, and practice daily routines. Motivation is high. Translate it into small, repeatable actions. Integration turns insight into behavior. Line up therapy modalities that fit your patterns. CBT or ACT for habit loops, IFs or EMDR for trauma, motivational interviewing for ambivalence, and body-based work for memory. Add peer support, 12-step, smart recovery, or trauma-informed groups. Involve family with boundaries and education. Build a relapse prevention plan with cravings maps, refusal scripts, and emergency contacts. Protect basics, sleep schedule, movement, nutrition, sunlight, and check-ins. Do not assume medications can be stopped after Ibogaine. Some people feel well briefly, then symptoms return. Coordinate with prescribers about if and when to restart or adjust antidepressants, sleep agents, or pain meds. Make one change at a time with monitoring. Safety beats ambition. Costs vary by setting, length, and medical resources. Often, USD 4K 10K. Expect transparent pricing including screening, dosing, medications, monitoring, transport, and aftercare. Red flags. No ECG or labs. Casual talk about dose without assessing you. Lack of emergency gear, pressure sales tactics, miracle cure promises, hidden fees, or no integration plan. If something feels rushed or secretive, walk away. Ibogaine is a catalyst, not a cure. Progress is non-linear. Cravings, mood dips, or insomnia can reappear. Respond with support, not shame. Useful questions. How do you keep patients safe? What is your emergency protocol and hospital partner? What aftercare do you provide? For yourself. Am I ready, resourced, and accountable? 2 snapshots. A patient transitioning from buprenorphine prepared meticulously, tolerated dosing, and used the afterglow to rebuild routines. 2 years substance-free with therapy and peer support. Another paused due to QTC and corrected electrolytes. Postponement kept them safe, and they later completed treatment successfully. Thanks for listening. This podcast is educational, not medical advice. Consult clinicians. Until next time.